Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Welcome, everybody. If you're participating in this live event, this is the Functional Medicine Discussion Group of Santa Monica, and we have a special program. We're going to be discussing SIBO, small intestinal bacterial overgrowth, and IBS, and we're going to have a group discussion with Dr. Sam Rahbar, who's an integrative gastroenterologist, and Dr. Ilana Gurevich, who's an naturopathic doctor, who's an expert on gut health. And if you're listening to this recorded, this is part of my weekly Rational Wellness Podcast, and I hope you enjoy it. It's pretty high-level science here, and we'll be discussing some innovative approaches on how to treat patients with these particular conditions. And keep in mind that these are experienced practitioners who often are seeing some of the worst patients who failed some of the basic frontline treatments. For example, a lot of their patients have seen a gastroenterologist or somebody else and have already tried a round of rifaximin, or have tried some of the antimicrobial herbs, or have done some of the other strategies that are being promoted out there. And so they're seeing some of the most difficult cases, but we're going to have a really high-level scientific discussion about how to treat these conditions. And I hope you enjoy it. And we'll get started right now. And now I'd like our two experts who agreed to join us tonight to tell us a little bit about themselves. Ilana, can you tell us a little bit about yourself and tell us about your new podcast?
Sure. My name is Dr. Ilana Gurevich, and I am a board-certified naturopathic gastroenterologist and a naturopathic physician who runs a practice out of Portland, Oregon. I am also in the process of launching a new podcast. I teamed up with two other physicians, Dr. Ami Kapadia, who's a functional medicine medical doctor, and Dr. Rebecca Sand, who has a history of working for the CDC in research and is also a naturopathic physician. And we launched a podcast called The Turd Nerds. And it's just, discussing really integrative gastroenterology topics from a research and an anecdotal practice stance.
That's great. I'm not sure about the name, but
neither is Google. They tell us it's offensive.
Oh, really? And Sam, can you tell everybody about yourself?
I'm a board-certified gastroenterologist, but I practice mainly integrative gastroenterology, and I incorporate the traditional with all the alternative methods and the functional medicine model into the GI practice.
That's great. So I was thinking maybe I could start off talking a little bit to just go into some of the basics about SIBO in case anybody who's on the call doesn't know much about SIBO or IBS. And then I figure we'll just let the discussion go where it goes. And the goal is for all of us to learn from each other and learn a little more about how we can help our patients. And so the history of IBS is that it is the most common gastrointestinal condition. It's been around for a very long time, probably exists in at least 10% of the population. And for many years, we had no idea what was the real cause of IBS. And it was often considered to be a stress-related condition. And it was typically patients would be either put on antidepressants, or if they had constipation, they would get a drug for constipation, or if they had a diarrhea, they would get a drug to try to control the diarrhea. And unfortunately, IBS is still treated that way in a significant percentage of the conventional medical community. But Dr. Pimentel, who, as I mentioned, in case you weren't here at the beginning, wasn't able to join us tonight, he's really pioneered that there is this actual cause of IBS, and that's small intestinal bacterial overgrowth. So what that means is that there's an overgrowth of bacteria in the small intestine, and that those bacteria, when you consume foods with fermentable fiber, those bacteria consume that fiber and produce gas. And now we know that there's 3 gases. And so we have hydrogen, which was the first gas we discovered, then methane and hydrogen sulfide. And so now the latest data shows that we have the Trio Smart or the Trio Smart breath test, which allows us to measure all 3 gases for the first time. And so that allows us to partition SIBO into 3 different categories. So we have hydrogen SIBO, we have hydrogen sulfide SIBO, and then we used to call it methane SIBO, and now Dr. Pimentel has changed the name to IMO, which is intestinal methanogen overgrowth. And I think a couple of reasons for calling it IMO is because it's produced by methanogens, which are actually not bacteria, and because it doesn't just exist in the small intestine, it also exists in the large intestine. And Dr. Pimentel also pioneered the use of a supposedly non-absorbable antibiotic called rifaximin for the treatment of SIBO. And he has shown that it is very effective for especially hydrogen SIBO. And then for methane SIBO, he's developed, he uses a combination of rifaximin and neomycin. And for the new hydrogen sulfide SIBO, as of this point, there are no new approved treatments for that. And Dr. Pimentel, my understanding is he uses rifaximin plus bismuth, essentially gives the patients Pepto-Bismol along with the rifaximin. And Dr. Pimentel has been doing a ton of research on mapping the microbiome of the small intestine. So now we know for the first time exactly which particular organisms, particular strains of bacteria are causing these forms of SIBO. So we know that with the hydrogen SIBO, maybe you guys can help me out. What are the 2 bacteria? E. coli
and Klebsiella.
And Klebsiella. And then with the EMO, with the methanogen overgrowth, we have Methanobrevibacter. And then recently, Dr. Pimentel has discovered 2 other bacteria that participate in helping to get the hydrogen to the methanogen. So the methanogens consume the hydrogen and then they produce the methane gas. And so he found 2 particular bacteria known as Ruminococcus and Cristianella. And so these particular bacteria are known as hydrogen donors. And he's also published a paper showing that there are 2 bacteria that help to donate the hydrogen to the hydrogen sulfide. So the bacteria that produce the hydrogen sulfide SIBO are Fusobacterium and Desulfovibrio. Those are the 2 main ones. And Enterobacteriacea is the bacteria that helps to donate the hydrogen to those. And so being able to determine exactly which bacteria is responsible for the SIBO and knowing where they exist in the small intestine is part of allowing us to come up with better treatments and better ways to diagnose and understand it. Sam, where should we go from here?
Let's go to the clinical stories again. I think if the SIBO is easy to treat, we wouldn't be here. Just take a course.
Absolutely.
Okay. So, I mean, obviously the challenge is when you have a recurrent SIBO, you have a persistent SIBO, or you have methane SIBO. And in my experience, when you see methane, it practically involves the entire intestine, the upper part, maybe extending all the way to the colon. Almost, they may have similar numbers for the most part. The question is that what allows the methanogens to grow in the upper part of the intestine. I can understand that the colon may be somewhat anaerobic, but the upper part of the bowel may contain some oxygen and air that we might have swallowed. For these bugs to grow, they probably need an anaerobic environment for this archaea to survive. I think the main question comes up, what has transpired that allows the methanogens to grow in the upper part of the intestine. Now, I share my own personal experience and observation. This is not all published, but is basically our interpretation of what we see and how these might be related. And the presence of methane, to me, generally implies some sort of immune dysregulation. There is something beyond just the SIBO, and the body has difficulty keeping the gut clean. And we also have to understand as what allows it to have an anaerobic environment without oxygen. And again, when I looked at some of the data as how they actually grow archaea in the laboratory, in the environment, in the methodology that they use, they add yeast and fungi to be able to absorb the oxygen and release nitrogen and create an anaerobic environment. This is the Journal of Bacteriology, Microbiology, and I believe in one of the conferences I shared the reference on that one. So when I see methane excess, I ask two questions: where is the fungus, and what has caused immune dysregulation to allow the body for these bugs to grow and the body become like a petri dish?
Now, Sam, how do we know? Is there a way to measure this immune dysregulation? Can we do a stool test that looks at secretory IgA? Is there a lab test? Should we, use one of the lymphocyte map tests, or how can we determine this immune dysfunction?
Right. I mean, you can do detailed immunological studies. Okay, I must tell you that we have not done that in all patients, but we did it in those that we felt that the problem was more intractable and we had to go further. But we did ask one question, that even though there is some immunological dysfunction or body's inability to deal with this, what would be causing that? And that brings us to the question of how that person or that individual has interacted with the universe. And that brings us to the concept of exposure to metals, to toxins, to chemicals, mold toxins. Many of these, they affect the microbiome directly, and they allow an imbalance to remain in the gut, or they somehow deal with the immune system. So generally, we just go and investigate that one and see if we can find risk factors. And at least in our observation, we have seen many patients, they have a variety of chemicals or toxins or mold or metals showing up in their urine or sometimes showing in their blood. And interestingly, it's not always one item. You cannot just pinpoint one single item. And I think we need to look at this cumulatively and maybe give a score to each of these things that we observe. And practically, the higher the score of abnormality that one can find in a urine toxicity evaluation, probably will correspond to the alterations of the microbiome and the symptom presentation that patient come to us.
Yeah. So when I get a SIBO patient, typically I do a stool test as well as a breath test. And if I see low secretory IgA, I'll use something like SBI Protect to try to help beef up the immune system. Do you try to address the immune system dysfunction in some way?
100%. I mean, we do a variety of things to improve the local immunity at the gut level. I mean, that is almost granted that there's going to be some alterations locally. Part of the defense mechanism that the intestines carry is the quality of the gel and the mucus layer that is sitting on the gut surface. And when we're dealing with this dysbiotic flora, there's clearly alteration of those mucus layers. And based on what I've seen from the literature, that exposure to the variety of the chemicals from the environment and detergents, they actually alter that mucus layer. And it makes it easier for the bugs to kind of hang on and not be so mobile, if you will. The body has difficulty to push them out, and they will get embedded into that mucus layer. And my emphasis has generally been on fungal elements because they have an ability to change shape from yeast into hyphae format, and hyphae has the ability to crack the wall. And those mechanical alterations, they allow bacteria to sometimes remain into those crevices. At least that has been one of my theories, that, you know, when we're dealing with recurrent SIBO, that in addition to whatever else is going on, there's some sort of mechanical changes at the gut level. And there's a whole protocol that we use to deal with that. I mean, I'm not going to continue talking as the only person here, see what Dr. Gurevich would like to share, but you know, obviously dealing with the gut surface and also the immunity locally is going to be crucial to the recovery.
I know every time I hear about these bacteria living in the mucus layer, the first thing that I think about is this is a biofilm. That's probably what's making it more difficult to get rid of these bacteria. And maybe we need the right biofilm busting agent to help us to do that. And I know, like a lot of people who deal with SIBO, we've tried various biofilm busting products and strategies, and not sure that any of them are all that effective.
I disagree.
Oh, okay.
So first of all, I could not agree more. I don't think that methanogen overgrowth is exclusively an issue with bacteria. I definitely think, you know, the more we think about it, the more fungus is one of the key courses of what's involved. And, you know, I always put the analogy of like looking at the forest floor, where the system that the way the forest floor communicates is all a fungus, because fungus is literally everywhere, which is why we have such fungal overgrowths. In my experience, very, very intractable methanogen overgrowth is actually pretty resolvable with using some aggressive biofilm strategies. The biofilm strategy that I'm using is I'll start with a pharmaceutical, you know, compounded medication using bismuth and DMSA or DMPS, whatever the pharmacies
It's
get.
just kind of like Paul Anderson's strategy.
It is Paul Anderson's, and I'll start there, and then I'll layer in, after a month, I'll layer in herbal antibiotic and then pharmaceutical antibiotics if needed. And, you know, depending on what's happening with stool tests, blood tests, I'm doing a lot of candida antigen testing right now. And if I find fungal overgrowth, then I'll also layer in antifungal, both herbal modalities and pharmaceutical modalities. And it's a long protocol, but you can definitely get improvement. And then, of course, you can't ever treat a methanogen patient without making sure they're actually eliminating and moving their bowels. And so we'll use some of our natural or pharmaceutical prokinetics to get it to move as well.
So what do you use to get rid of the fungus?
So I have what I lovingly call it my antifungal parade. So I'll use some pharmaceutical biofilm disruptors. That's the Paul Anderson one. I'll use some interesting enzyme biofilm disruptors. There's some interesting data using hemicellulose, using serrapeptidase. And so I'll put patients on that. And then I'll circle them through antifungal herbal agents so they don't ever develop a tolerance to it. There is some really interesting data that's in vitro that shows that using gymnema prevents the yeast from budding. So that's how I try to.
So gymnema is an herb we typically think of as helping with blood sugar problems, right?
Yep. That's exactly what it is. And there's, in vitro data that shows that it prevents the yeast from budding. And
so can you recommend a product and a dosage for that?
So I'm using Wise Woman Herbals. They have a gymnema capsule, and I'll go 1-3 times a day. I think Now also has a really, really affordable product that's just gymnema. And so that will be in the protocol. If I can find Candida, I still love nystatin. I know it's not popular anymore, but I think nystatin is generally very well tolerated and very safe. And then I'll rotate through that old formulation SF722. They've just rebranded it. I'll have patients on that for a bottle, and then I'll switch them to oregano, or I'll switch them to Colorex, or I'll switch them to ITI has a really great formula called Yeast Arrest or Y Arrest, something like that. And I'll just cycle through one product, and as soon as they finish the bottle, and we're looking at a minimum 3 months, but I mean, often people were looking at 9 months to a year.
So let's, if you don't mind, can you give us your entire protocol?
Yeah. So, okay. So we're assuming that this patient has both methanogen overgrowth plus a fungal overgrowth that we found either in stool or more likely a Candida immune complex, and even possibly Candida IgM, IgG, or IgA. I don't do a lot of urine testing. I don't do the OAT testing, but there are some markers in the OAT test that would also show you fungal overgrowth. And so what I do is.
So let me stop you. Sorry. What's your best test for fungal overgrowth?
So I like Quest and LabCorp have a test called a Candida immune complex, which is this test goes back to, I think, 1950s or late 1940s, early 1950s, that shows that when that marker is positive, there is actually intestinal candidiasis. So I'm going back to way back in the day, and I'm using that marker. And then I'll also look for a Candida IgM, IgA, and IgG. And so we'll go, this is an intractable SIBO patient. We've tried all the things that should work. They haven't worked. You're treating the wrong thing. You start looking. So I'll do that. And I'll also probably run a stool assay that's provoked. So I try to break down biofilms before they collect their stool, and I see if I can find some fungus in there. If I find fungus, I'll start them on the bistiol complex that Paul Anderson came up with, and it'll take them a month to get up to therapeutic dose. And then after that month, I'll introduce the biofilm, the enzyme biofilm disruptors. Right now, I'm using a product called Biofilm X. Enzyme Science also has a pretty interesting enzyme product that has a high dose of hemicellulose, which also has some in vitro data.
Do you like Interphase Plus, which is a very popular one?
I use Interphase Plus to provoke. I don't love the the EDTA. Is that what's in there?
Yes.
Yeah. So I don't like that long term if I don't have to, especially if I'm giving them the biofilm disruptor with the bistiol complex. And so that's a DMSA. So I kind of will stay away from Interphase if I'm using the other biofilm agent.
And the biofilm buster with the bismuth is, how long are you using that for? Because potentially using a heavy metal like bismuth could be a problem used for a long period of time.
So it seems that when you're making the bistiol complex, you're actually protecting the body against long-term use of bismuth on its own, right? It becomes a bigger molecule, and so it doesn't cross the intestine as easily, even with intestinal permeability patients. So there is interesting research that says that it's actually safer. And I think Paul talks about it on your podcast, actually.
Yeah.
I think I heard it from you. So I'm using that at a minimum 3 months, but with these chronic patients, you're looking 9 months to a year easily. And so I'll do that. And then I'll introduce the enzymes and the herbs in month 2. And I'm starting with SF722, which it goes like indoleic acid and nucleic acid. They've renamed it.
Right.
Just
Is that the Thorn product, I think?
one
Yeah.
product. Yep.
Okay.
And you work up to, they're like little gel tabs. So you work up to
I think you have to take like almost the whole bottle in like 5 days or something.
It's like little gel. They're like little gel tabs, but it's
And you have to take like 12 of them or 15 or something, right?
10. Yeah, 10 a day.
Yeah.
So
Okay.
5 times a day. And then I'll kind of circle through the herbs as we go. And usually, honestly, the first thing that happens, and I don't know if you guys can see this as well. The minute you start, and then I'll also put in nystatin. The minute you start nystatin, generally their bowel movements start moving. I mean, it is like, not always, but it is 70% of the time, they will immediately have better evacuation just by putting in nystatin if candida or fungus is the underlying cause.
And are you addressing diet as part of this program?
I always say, I always have my spiel. Like I'm not one of those naturopaths that give people eating disorders, but I am one of those naturopaths that believe that you shouldn't eat garbage. Your diet can't be 100% processed, 100% sugar. And I do think the protocol works faster if you're not eating a ton of processed sugar.
Yeah, I mean, I would assume some version of an anti-candida diet, right?
So I have a personal story. I was taking this road trip with my girlfriend when we were in school, and she decided that was the perfect time while we're driving to Canada to go on her anti-candida diet. And I have never sat through so many mood swings in all of you know what I mean? So I'm not a big fan of that restriction. I'm a big fan of eating a really holistic, vegetable forward diet that's not super processed. Sam, do you agree?
Yes.
What kind of dietary recommendations do you give to your patients who you see who have SIBO, and then especially those who where you think fungus is an issue? And then somebody also asked, what about restricting fungus in the diet, like mushrooms and things like that, and foods that might be, the coffee, which might have fungus on it, etc.
I'll try to keep a little bit of balance. It really becomes difficult more than a month to be in such a strict diet. And if you keep the carbohydrate too low, occasionally then mood problems, anxiety, and other things start to develop. So, I mean, I generally try not to take coffee away from people. I ask them to use maybe an organic version and something that probably doesn't have glyphosate. But, we're all going to have some exposure to fungi. If they use mushroom and other things, I do recommend that those are cooked or highly esteemed, so at least those bugs might be killed if they consume it. So as a Libra, I usually try to keep a little balance there, but I'm interested to see what Ilana is going to say.
So basically, when I'm talking to patients with diet, I think pesticides, herbicides, fungicides, all of those need to be, because those are basically just antibiotics that are making the microbiome more deteriorated. On top of that, I think that as much as you can give me a vegetable forward diet, I think that's going to make all the difference. That's going to give you your fiber. That's going to increase your biodiversity. That's also going to help elimination if you're getting both soluble and insoluble fibers. And then I'd say, avoid the garbage, which we all eat a little bit too much of as Americans, or at this point, the whole world. So avoid all of the process. I'm not opposed to grains. I think whole grains are super useful. I'm not opposed to proteins. I think any way you can get your proteins, that's great. And then just, avoid what doesn't make you feel good. But I feel like I went through the whole FODMAP where everybody got a FODMAP diet when they had SIBO, and I just witnessed the eating disorders. And with all due respect, the minute they stop that diet, they're having exactly the same symptom picture. They just now have a phobia of food. So my goal is not, I don't actually take very much away. I just try to educate them on what eating a holistic diet looks like and, lead them in that direction. And I'm a really big fan of meal delivery services. And so, I educate patients where if you don't want to do the cooking yourself, let's get you one of these organic meal delivery services where you can actually eat quality food that tastes good.
Now, Dr. Pimentel has been working on using lovastatin for methane SIBO because there's data showing that lovastatin can block the methane gas as part of the treatment. And I wonder if either of you or anybody else who's on the call has experimented with using something like red yeast rice for methane SIBO.
I thought that
I don't have any experience with it. I don't think it's strong enough to handle this.
I thought that I thought that he had some theories about it, but it didn't come out in the phase 3 trials. But I don't know. I'm not up to date.
So yeah, as far as I know, so far it has not worked out, but he's still talking about developing it. I think the problem with the trial was that they weren't able to develop a form of lovastatin that only stayed in the gut.
I've never tried it.
Yeah, I've experimented with red yeast rice, and I had a couple of patients where I thought it worked, and other patients where I thought I couldn't tell if it worked or not.
Welcome to SIBO.
Well, that's the thing. The thing about SIBO is it seems like we've got this easy disease process. We've just got too many bacteria, and it should be easy to eradicate, except that it's not. And why is it so hard to eradicate? Is it because we're not killing the bacteria? We're not getting to them? They're difficult to kill? Is it because maybe there's multiple layers of problems? Maybe the patient who has SIBO, as you guys have both talked about, also has fungal overgrowth. Maybe there's other issues with their gut. Maybe they have gut hypersensitivity. Maybe they have food sensitivities. Maybe there's other issues besides the SIBO.
There is always other issues besides the SIBO, because there is that, there's like a quarter of patients, maybe a fifth of patients that you give them a round of rifaximin and it's like magic and they don't see you again for a couple of years. Like there is a subset of people that are very easy to treat. I don't think they're coming into our office anymore because, they're getting caught by the regular primary care doc or the regular gastro. I think, unfortunately, I think that our population is just kind of centralized on, they have a lot of other things going on. Toxicity is one of them. Fungus is one of them. Hypersensitivity is one of them. They're complicated.
Right. Now, Ilana, when you do the, I'm assuming you're using a trio breath test. I heard Allison Seebecker say that she has the patients do it over a 3-hour period of time, whereas it's recommended to do it for 2 hours. What do you do?
I'm having them collect breath every 17 minutes.
So that makes 3 hours, right? Because the recommendation is every 15 minutes, right?
Yep.
And now, can you explain why?
Because I feel like it's important to see when they get into the large intestine. I feel like it's important that that gives us a whole different set of information.
Well, explain what that gives us, because once it's past 90 minutes, it's no longer the small intestine, or we assume that's the case. So then why do we need to know past 90 minutes? And certainly, why do we need to know past 120?
So I think that with intestinal methanogen overgrowth, we can assume that their transit time is greatly delayed. So then, if we're going through that test too quickly and they're highly constipated, I feel like we might be missing it, especially if it's affecting the bottom of the small bowel, right? So that's why I like to go longer, especially with IMO patients. And then I do like to see that drop and come up again to make sure that I can kind of locate where I am in the bowels. And I don't know if that ever held water, but I think I've been doing this too long of a time to not feel comfort with seeing it.
I wonder if anybody has, I'm going to switch now to hydrogen sulfide SIBO. For years, we didn't have a hydrogen sulfide breath test. So we used to use a flat line for 3 hours as indication of hydrogen sulfide. Do we know at this point, has anybody really done a serious look at patients who had a flat line as compared to patients who test positive for hydrogen sulfide on the new test?
I don't know.
What do you think, Sam?
I'm not sure.
Okay. Now, let's talk about strategies for treating hydrogen sulfide SIBO.
For me, bismuth is king. I think bismuth has to be in that treatment plan, no matter what you do. I think bismuth has to be in that treatment plan.
Okay, business plus, are you using rifaximin?
So I'll use bismuth and rifaximin, or I'll use bismuth and herbs, depending on cost and patient preference.
Okay, so what are your favorite herbs for hydrogen sulfide SIBO?
I find that oregano probably works better than anything else. I really, really like Alimed in there too. If, it's always a cost thing, but I really love, strong allicin. And then, I'll play around. There's some Chinese herbs that I like to play around with that sometimes have efficacy. It's in Chinese medicine, it's Huang Bai, Huang Lian, and Huang Qin. So I think it's philodendron, Coptis, and Scutellaria. Coptis will sometimes flare them a little bit too much. I think it's high sulfur, but Scutellaria and philodendron are actually well tolerated by some.
Interesting. Can you give us an oregano product that you like? Do you like the oregano oil? Do you like the dried oregano powder, like the ADP?
So I'll use either ADP or I'll use the oil of oregano by Gaia. Okay. I don't I'm getting my stuff from Full Script, and something's on back order every other week. So it's
I know.
Kind of whatever I can get. Yeah.
How about you, Sam? What have you found for the most effective strategies for treating hydrogen sulfide SIBO?
I use the combination of Xifaxan and also the bismuth, but the bismuth has to be compounded without the salicylate to avoid any salicylate issues. Either you can use bismuth citrate or subnitrate. But I also have had some good luck with mesalamine. Wow. And indeed, I know of cases we have had where, this was a problem and there was a lot of abdominal symptoms. And even though the patient did not have inflammatory bowel disease, but the mesalamine was a game changer in that setting. Now, whether it was because of controlling the hydrogen sulfide or something else, is hard to know, but I know that's one of the mechanisms that it actually works.
Hey, Sam, are you ruling out microscopic colitis with these people first? Or not necessarily?
Well, I don't use mesalamine for microscopic colitis. Okay.
There's data. I feel like mesalamine actually for really complicated microscopic colitis patients, there is data that it has efficacy, and I've been using it with those patients, and I'm wondering if it's what it's treating. You know what I mean? There's a couple of papers. I can send them over to you if you want to see them.
Yeah, no, mesalamine has been used for microscopic colitis. It has been used for irritable bowel syndrome. All of these, they have literature out there. But the question is, how does it work? And, I think it may be tweaking the hydrogen sulfide, and that's why I've used it. And, in a few cases we have had good success with it.
Interesting.
Somebody asked Sam for the dosing and the timeline for the use of mesalamine.
I use equivalent to pentasa, not other types of mesalamine, only pentasa because it opens up in the small bowel. It also comes in a granule, so you can have the patient to open the capsule. And if you buy it from Canada, it comes in a sachet, so it's actually in a powder format. And because the concern many times with the small bowel, the majority of the mesalamine products in the market, they deliver to the colon, but you need this thing to open up in the small bowel. And if you have patients with unexplained abdominal pain, components of, you can call bad IBS, and some suspicion of inflammation going on that is hard to define, mesalamine might be an option. And if you search, you will actually see it has been used for the setting of, quote, irritable bowel syndrome with some success.
How many grams? Four doses a day?
Well, you need to get up to about 4 grams a day if the patient can tolerate it and they don't have side effects.
Bernie said that he used oregano oil and ended up in the hospital with gut inflammation.
I'm sorry, what is it again?
Bernie Bubman mentioned that he used oregano oil and ended up in the hospital with gut inflammation.
I mean, I don't think we have enough data to understand what the problem was. A little unusual.
I do think it's a strong antimicrobial. I think it's a very strong antibiotic, though, oregano, at least in my formulary.
Yeah, it depends on the person. I know I've used oregano oil for myself, and for me, it's a great product, but it can be very inflammatory, especially using the oils. That's why Ilana mentioned that she uses ADP, which is a dried form of oregano, and it doesn't have the volatile oils. And some people find that that's more tolerable, correct?
Yep. And you can go higher doses.
Yeah. I want to make a comment about the use of herbs, and obviously we all use them. We have had instances where you have a case of, evidence of fungal overgrowth and evidence of SIBO, and said, okay, which one do you think it might be the player? And we have used herbal combinations, including allicin, neem, FC-Cidal, dysbiocide, ADP. And in a few instances, and again, this is a small percentage, that when you attack the microbiome like this, there may be a predominance as which one of these kingdoms they get more affected. In other words, if the bacteria got more affected, you can actually create a fungal predominance. And I've had cases where people within a few days of taking 5 herbs, that's a lot of, they actually felt a lot more bloated, which means that there was a lot more fermentation going on. In those cases, we switched to an pure antifungal with some success. Now, this is a limited observation, but those cases are so prominent in their presentation that you would never forget. How would somebody become, more bloated while they're taking 5 herbs at the same time? The same thing happened in one instance. I think I discussed it the last time, that the patient was on elemental diet and rifaximin together for SIBO and fluconazole and nystatin, all of those. And within 3 days of the elemental diet, the patient became more bloated on elemental diet. So we stopped everything and we switched to itraconazole. And within a few days, the bloating, everything went down again. So it was obvious there was resistance of the fungi to those elements. And even though there was no more SIBO, but the fungus took over in that setting there.
Now, as a chiropractor, I can't prescribe medications, but when I use herbal products for patients with SIBO, I'm aware of the fact that most of the herbal products that are antimicrobial are also antifungal. So I always feel good about that fact that we're fighting against the fungal overgrowth as well.
And I often, a case like that, I often wonder if there's like a histamine component. And especially if the fungus is overgrowing, the way I see it in my practice is, fungal overgrowth will usually lead to a histamine overproduction. So if I see something like that, I'll try to see if I can get some mast cell stabilizers on board to see if that would, address some of the side effects. I also wonder, that's like a big protocol. I'm often wondering what's left in there. If we're getting rid of the bacteria, we're getting rid of the fungus, then we've got viruses left and we've got the most resistant of all species. So I'm like, I wonder what's left in there.
And that brings up another question, which is, when is it beneficial to use probiotics? Because as we all know, even using herbal antibiotics or herbal antimicrobials, they could possibly have a negative effect on the microbiome. I haven't really seen it, but it's possible. Certainly, we know that using antibiotics can have a negative effect on the microbiome. And is it appropriate to use a probiotic at the same time? A lot of people like to use the analogy that we have a parking lot, we have X amount of parking spaces, and if you leave some of those spaces open, they'll get filled up by potentially pathogenic bacteria or fungus. So let's put a car in there. Let's put some probiotics in there, or
and just like
and so typically when I have a patient on a SIBO protocol, I'll use a spore-based probiotic with the idea that it's not going to open up in the small intestine, supposedly.
I usually hold on probiotics until what I lovingly call phase 3. You know, when we've kind of done a lot of the treatment, I'll try to introduce probiotics then. How about you, Sam? When are you using them?
I don't use probiotics during the treatment and very cautiously after the SIBO is treated.
Because you've seen patients flare?
Yeah,
Or the data is not strong enough?
Generally, I imply that you take probiotic, there's always a chance you're going to get more bloated again. It's not completely predictable as how the body is going to handle it. Bear in mind that when we give probiotics by mouth, we really mean the probiotic to land in the colon and see the benefits there. And what about if it didn't? What would happen if we put probiotics in our eyes? You know, it's just not, sometimes it may behave like a bad thing. Again, I generally go slowly on probiotics, although patients ask us and they want to start early, but I go cautiously.
Do you avoid fermented food as well? What's your stance on fermented food?
I use fermented foods and also prebiotics I like. I use the sun fiber, the PSGG, because that's easy. It generally doesn't cause gas. It's interesting. And then if they tolerate it, I may add some psyllium slowly in a small amount to see if we can replenish the microbiome that way after the treatment. During the attack phase, when you're trying to correct the fermentation process, I think it's unwise to put real probiotics there. Indeed, one of the questions comes up that whether it's wise to use Saccharomyces boulardii. And to me, it's a double-edged sword. And if I'm dealing with a fungal clinical picture, I usually do not use S. boulardii. Okay, now I have had people who said it helped them, but that's not always the case.
And do we think, somebody just asked about soil-based, that same thing as spore-based bacillus. Do we think that the claims that the spore-based probiotics don't open up until they get into the large intestine, do we think that that is the case, or do we not know?
I don't know.
You know, I don't know the answer to that question, but I can tell you one thing, that about half of the patients who have taken a spore-based probiotic, they will complain of bloating. This is not a magic bullet. I mean, I think it's good to keep it in mind. And I definitely would do it down the line after the attack phase, but in a small amounts, and you really have to have them experiment with it to see how the body works with that.
I have seen more people flare from this soil-based probiotics or the spore-based than any other probiotic out there. I do think Dr. Zwicky, who's just an amazing researcher, talks about how it does upregulate the Th17 pathway. And so you are getting upregulation of, the immune response, or, the autoimmune response. So if I use it, I'm going to go very, very slow. I'll start with a quarter cap every other day, because I do see people get angry with it. And I will also say, from my perspective, I am definitely having a fermented food moment. I feel like, when you look back at virtually every culture in history, fermented food has been one of the staples of their diet. That is not on accident.
What's your favorite fermented food that you like to recommend?
This week, it's definitely kimchi. We just went to the Asian market. Next week, it might be sauerkraut, maybe yogurt. I don't know.
How about yourself, Sam? Do you ever?
Well, kimchi, again, the question is that, are you aiming for bacterial, fermented material, or for fungi? And I think kimchi has a little bit of both. I don't think it's all bacterial. I think it may have some fungal components in. It's probably safer to use those than to use the, nutraceutical versions. But again, the key is the amount and how one would experiment with it.
And the patient. I also think the key is the patient. If you're having somebody who's very, very sick and very, very sensitive, I don't know if I would jump on the fermented food train. But if you have something that's a little bit more resilient and you feel like the treatment trajectory is going kind of how you expect, that is absolutely going to be in my phase 3. So I think it's also, everything that we're talking about is obviously exceptionally patient dependent.
Right. And I would like to point out to everybody who's listening to this discussion that if we had several other SIBO experts, we would hear several different opinions, and a lot of the stuff we're talking about, people have many different opinions about this. There's one prominent practitioner out there who treats a lot of SIBO, and he feels like probiotics are the first line. That's what you should give. And he feels that there's enough evidence that probiotics have antimicrobial properties.
I also like the polyphenols. I think those have gotten more attention, and we need to think about those more as supporting the local immunity of the gut and the recovery process.
I agree.
Have either you, this is not in the acute phase of SIBO, but have either of you utilized any of the probiotics that are the Akkermansia muciniphila and those other products that are the anaerobic bacteria that are being produced for the first time from I forgot what the name of the company is. Pendulum, right.
I've never used them.
Okay.
What do you mean by anaerobic? Talking about the Akkermansia?
Yeah, Akkermansia. They have an Akkermansia product, and they have a product with Akkermansia and a couple of other similar probiotics that they have a study shows it reduces blood sugar.
Yeah, I actually use Akkermansia when I see it is low. The key is that Akkermansia tends to eat up the mucus layer. So there might be a good theory that when there is fungus and the mucus layer becomes quite thick and the fungus gets embedded there, Akkermansia may actually come to the rescue and be able to loosen up that mucus layer and makes it easier to remove the fungus. So having a low Akkermansia and a fungal clinical picture is probably the worst combination. Okay.
Oh,
so
interesting.
I use it sometimes to see if I can replenish what's missing here.
Yeah, and there's some data showing, you mentioned polyphenols, that certain polyphenols, I know flaxseed's one of them, but berries, a bunch of polyphenols can help to feed Akkermansia. But it might be interesting to try adding the Akkermansia probiotic as well.
Do it gently and in a small amount, and be careful, because Akkermansia in some literature actually has shown to promote inflammation. It's not completely clear why that would happen and how you can separate those. One of the things that would actually help to support the growth of Akkermansia is omega-3s. So that might be something to keep in mind. If a person is on a low omega-3, we can incorporate that as part of the recovery.
Okay. I don't know if either one of you have heard of any practitioners experimenting with removing the removing the antivinculin and the anti-CBT toxins, the antibodies, by filtering out the blood. No, I think
plasmapheresis.
Plasmapheresis, yeah. I believe that Dr. Pimentel is working on doing that.
Risky and very expensive, and probably not going to get covered by any insurance company for that. Now that you said those antibodies, we have been looking at antibodies on patients who have had SIBO, especially the persistent ones. And how do you explain when these antibodies are not there, they're negative, and somebody has recurrent SIBO? I mean, there must be some other sort of either immune dysregulation or physiological alteration that allows the gut for these bugs to grow. And as I mentioned, earlier, I think the fungi, and I think Ilana pointed out that the fungi are major players, and I think they contribute by mechanical disruption. Means that it's not only that you have a distorted microbiome, you now have a surface area that is disturbed, is mechanically disturbed. It has cracks, it doesn't have the smooth, it used to be like an ice skating, and the box can float on it, and now it has cracks in the wall.
Mm-hmm.
For anybody who's not sure what we're talking about, there is a blood test for SIBO that measures the antivinculin and anti-cytolethal distending toxin antibodies. This comes from Dr. Pimentel's theory that a significant percentage of patients who have SIBO, that it starts with a bout of food poisoning. And then the bacteria like Campylobacter that cause the food poisoning, the body, those bacteria secrete an endotoxin, cytolethal distending toxin. The immune system creates antibodies to cytolethal distending toxin, and then those antibodies cross-react with a protein called vinculin, which is part of the nervous system of the gut. And then those antibodies attack the nervous system of the gut, and that damages the motility of the small intestine. And that's what leads to the SIBO. So that brings up the question, how do we best address the motility?
So my favorite is always prucalopride. I think prucalopride is still magical. I think that there's definitely a subset of people that it's not magical for, but a lot of people it's magical. So that's my pharmaceutical go-to, especially with IMO patients who are just severely constipated. Natural agents, I think artichoke and ginger, there is data on it, and it seems to work for a lot of people. That's my experience.
Now, do you use prokinetics for patients with hydrogen and hydrogen sulfide SIBO as well?
Not religiously. And if I do, I really will stay in the ginger area, because they're already moving a lot. So I want to make sure I'm not giving them pharmaceuticals.
Right. Now, I know in the past I've talked to Dr. Pimentel about this, and he distinguishes between the motility of the gut and the MMC, the cleansing waves that happen when you haven't eaten, and that those are controlled by different mechanisms. So therefore, a patient who has hydrogen SIBO, who has increased motility, might still lack the migrating motor complex, the cleansing waves that keep the bacteria from building up. So we still might want to use a prokinetic in those cases to make sure that we help clear the SIBO.
I'm just super resident. I'm very, very cautious about using anything too strong. So I think the herbal agents are effective and generally well tolerated. And I think the pharmaceutical agents are too strong for that population, in my experience.
What do you think, Sam?
We may have a little bit of a difference of opinion. I mean, I use antifungals pharmaceutical approach at first. And
right.
Part of the reason is that I like targeted attacks. So I understand what am I dealing with. Herbs are good, but they're broad. They're too, I understand I'm capturing more bacteria, more fungi. There's a trade-off. But as far as the die-off, yes, the die-off could be stronger, but that we can adjust it by taking less of the medication and less frequently. Like one patient I had to work with recently, I felt that the chance of die-off was high. I just asked them to maybe use half a tablet of a fluconazole once a week, and if they tolerated that, to go to twice a week. So you can kind of go slowly and also see what the patient's comfortable with. If they're more comfortable with herbal approaches, you can go that way.
And do you use prokinetics either during the active treatment or afterwards to reduce the recurrence, which is when Dr. Pimentel tends to use them?
I don't use prokinetics during the treatment. I don't want to push the drugs out. I want them to hang out in the small bowel. So I would use them afterwards, but not during.
Okay. And do
You
you
know, it's
use,
interesting.
I'm sorry.
One of my selling points on the herbs is that they are broad spectrum. That's one of the things I like about them. You know, they're less targeted, they're less specific. And, you know, one of my, like the way I think about it is humans evolved with plant matter for, 200,000 years. And we've had pharmaceuticals that are targeted for about, 100. And our health has significantly declined in that small amount of time. So that's one of the reasons why I prefer herbs over the pharmaceuticals if the patient is concerned.
Oh, shit. I'm sorry.
They're both good.
So what do we think about why the patients ended up with SIBO? Do you both think that what percentage of cases do you think are probably related to food poisoning and decreased motility? What do we think are the causes for the SIBO? And also, do we think that hydrogen, do we think that a stomach acid reduces the risk for SIBO? Because that seems to be in question now that at least Dr. Pimentel has talked about the fact that PPI use does not increase the risk for SIBO. So does that mean that stomach acid doesn't help to reduce bacteria growth in the intestines?
In patients who have low acid and they have SIBO, there may be other mechanisms involved other than just the low acid that is contributing to the SIBO. I am not convinced that the PPIs increase the risk of SIBO, although conceptually that makes sense. It's just something in practice we have not seen to be a strong association.
Yeah, no, Dr. Pimentel has said the opposite. He said that he's convinced that they don't increase the risk of SIBO, and he seemed to hint that they might be beneficial for use as part of the treatment for patients with methane SIBO.
Right. I don't know if I'm going to incorporate the PPI in the treatment of SIBO, okay, despite that comment. But if I have to use it for somebody who has bad acid reflux and we need some temporary relief, it probably would be okay.
I agree.
So let's see, anything else we haven't covered? They did not answer as to the cause. So what do you think is the cause of SIBO?
How much time do we have?
We can do a couple more.
You should bring Mark back again to discuss that one. I mean, come on, this is going to go on for a long time. I think, as I said, in our experience, the alterations of the microbiome that we see, I think it has a lot to do with how that individual and the universe were interacting. Obviously, stress, lack of sleep, late eating, alcohol, use of antibiotics, all of these things are the common ones we know. History of food poisoning, vinculin antibody being positive. But then there's a subset of patients that are just exposed to chemicals. We see SIBO and C4 combinations quite common in people who have been exposed to mold toxins. And this is our own experience looking at a lot of patients that a SIBO that is really high hydrogen or the methane is high, it may very well be associated with a mycotoxin exposure or high level of BPA or glyphosate or phthalates. We are seeing these associations, and hopefully at one point we can publish this so we can further confirm that. But as an observation, I find that as a subset of patients, they are dealing with this type of problem.
I totally agree. And it was beautifully said.
Thank you.
And Sam, you've also published on the fact that there are cases of patients with SIBO who also have Lyme disease, and that seems to be a factor.
Right. Back in 2014, I presented the data that if you see somebody with high methane, that suggests immune dysregulation. And if the clinical picture fits, you must think of Lyme disease or other tick-borne diseases. We published this in 2021 in our experience, and the prevalence of SIBO was quite high in the subset of patients who had tick-borne disease. But when we compared it with the control group and the people who did not have the tick-borne disease, they also had a similar prevalence. However, I want to emphasize in that study, we use a cutoff of 80 minutes for SIBO, not 90, not 100, 80 minutes. And the reason I did that, just to make sure there was no question that if there was SIBO, it was SIBO, and it was not a borderline case. So only people who were abnormal at the 80 minutes mark, we included in that study.
All right, great. Well, thank you both so much for filling in at the last minute. For anybody who just came in later, Dr. Pimentel wasn't able to join us, but we hope to have him in a future meeting. And thank you, everybody, for participating. And we hope to see you next month.
I hope so, too.
Thank you.
Nice to meet you, Sam. It was lovely hearing you speak. Very nice to meet you.
Thank you. All the best. Take care now.
Bye, everybody.
Bye.
And thank you for making it all the way through this episode of the Rational Wellness Podcast. And for those of you who enjoy listening to the Rational Wellness Podcast, I would certainly appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. That way, more people will be able to discover the Rational Wellness Podcast. And I wanted to say thank you to all the patients that we've been working with at our Weitz Sports Chiropractic and Nutrition Clinic, most of whom we've been able to help with a range of various health conditions, from various types of gut disorders to thyroid and hormonal issues, autoimmune diseases, and various other cardiometabolic conditions. And so I very much appreciate you, and I'm excited about going forwards, helping you to improve your health on your journey towards optimal health. And I wanted to let everybody know that I do have a few openings now for new clients, and you can take advantage of that by calling my Weitz Sports Chiropractic and Nutrition Santa Monica office at 310-395-3111, and we can set you up for a new consultation for functional medicine nutrition. And we can get that going as early as the new year. So give us a call, and I'll talk to you next week.